likely bound to keep having series of pandemic outbreaks based on the changes that have been seen as per the pathogens in the last since 2011 or in the last 2 decades. So it is time for the world and all of us to act together and to ensure that we leave no one behind. And that is the slogan which we need not to just say in the mouth, we need to put it in practice. We that are in programs, if we are designing programs that does not incorporate everyone, then there is a likelihood that someone will be left behind. And that someone that will be left behind might be the one that will make you achieve the results that we might want to achieve as per taking us to the next level. Also, from the recent pandemics that we have had, we also discovered that while we have systems functional in some places, most of these health systems are not resilient. And what we mean by resilient, they are not as dynamic as we expect them to be. Also, most of these health systems that we have in many countries are designed to address what we probably call the primary health care, the basic health needs of people. So the orientation that most of the health systems that we have globally, including the developed society, is that they are there to respond to basic health needs of people. So now, WHO and partners have discovered that it is high time we begin to change the narrative and start building the orientation of our health systems and those who practice in the system to think of health security beyond basic primary health care provision to the population. Because when we encounter pandemic outbreaks, we don't pray that we have something close to COVID-19 in the nearest future, but nobody knows the future. And if you look at the situation we have today, if we have something close to COVID-19 as we had in 2020, there is likely that we may not get different results because the state of the health system is not as different from the way it was before. So we need to start changing the orientation and building our system to make them not just functional, but dynamic, with capacity tested, and easy to, with making them to have easy scalable and adaptable structure, so that in case there is any need to change the way they operate, it will not be difficult to scale it up and to adapt them to meet the health needs. Basically, or most importantly, the pandemic health need. Also, the studies that have been done, or the outcome of various interaction reviews, shows that you may have a good system, you may have all the resources, but the resilience of the people also matters when it comes to how we survive in a pandemic outbreak situation. So we need people that are well informed and that are committed and that are also supported, and a population that are responsible for us to have a different outcomes when it comes to pandemic outbreak. Especially, though we don't pray for it, as I said, but nobody knows what can happen tomorrow. So we need to get our people informed that anything can happen, and while anything can happen, the way we subdue COVID-19, we can always subdue any pandemic that happen to us at any time. Also, one of the lessons that is learned is that while the animal health people are doing their own, the human health people are doing their own, the world has come to the point that all of us need to think together, reason together, because most of the pandemic outbreaks that have occurred in the last 20 years have linked to animals and livestock. And it is high time we that are working on human health to integrate much more closely with those who are working on animal health, for us to be able to do better when it comes to preparing for the next pandemics and responding better to the next pandemic. Also, one of the major lessons that was learned, even though the results varies from one region to the other, is that there was a reduced attention or neglect of other diseases that have been attended to in countries or other programs. And communicable and non-communicable bodies were observed to have increased, are observed to always increase with pandemics. But when we look at some literature review on HIV, we discovered that from what literature review says that the there was no increase of COVID-19 that is due to HIV. Also, result of whether the mortality or the outcome of care goes down or not also was unequivocal from one country to the other, which means that some countries did very well, while some countries also performed poorly. A study on that has been conducted in Tanzania. I don't have the permission to speak because the report has not been submitted, but the result is also mixed, if I may summarize it like that, for Tanzania. While in some area of HIV care there was a positive side, in some area there was some good side. So which means that we did well in some, we didn't do well in the other area. But generally, pandemic outbreaks affect other health care because all the attentions were shifted or was shifted to COVID-19 and pandemics. And this is what usually happen with a major pandemics in countries that are affected. And also we discovered that the world and each country need at this time much more than before the political will and commitment of our leaders. We have been talking about resources, that it is time for Tanzania to commit more money to funding HIV program. It's not just only HIV program. So many. It is time for us to have our leaders be more committed to getting ourselves prepared and ready for every programs that we are actually participating in, including HIV program and including preparedness for the next pandemic. Because the more we depend on the foreign donors, the more the world will not be able to even address the preparedness challenges. And of course, while they attempt to solve their own problems, our own problem will remain, because it's not that we don't have the strategies, it's just because we are not committed. Our leaders are not, sometimes not well informed, so which means we that are in the technical section need to also, in addition to getting their way, we need to make them understand. Because some of the language we speak to them, we need to change our language and communicate with them in such a way that will make them to give more attention and be ready to commit more resources, more time to solving preparedness and readiness needs for the country. We are all aware that Sudan virus disease is very near to us, and if I may ask some of us here, what do you think, how ready are we in case we have something close to that in Tanzania today? Many of us may not be able to say much because we are not even aware of what is being done. But at this particular time, many citizens are supposed not to, it's not just to have the narrative of it is there. We should be prepared as a people. That's what we mean by resilient people must be informed and be well prepared and know that it can happen anywhere at any time. So getting the political will for our leader and the commitment of our leader is very important. And lastly, the evolution of science, technology, and innovations is a reality that we have seen with COVID-19, especially with the development of vaccine within 1 year, which has never happened in the history of the world. Though some have issues with that, but at least it's over 2 years down the line, and the studies are going on, and we have not seen much of we've had no significant strange outcome as per those who have received the COVID-19 vaccine globally. So which shows that science innovations have come to stay. And it is time for us as professionals to also think, innovate how we can wiggle our way around the challenges that our programs are facing, especially the HIV programs that we have. I saw when the presentation was going on that much progress has been made, but the remaining how do we move forward? It requires us to think and to innovate and see what we can do to get the result better. So what do we need to do differently? One, there is what we call the health system for health security. As I said earlier, our health systems, it is time for our health systems to start, for us to start changing the orientation of our health system practitioner to make them see health security as a responsibility of all. Until we begin to do that, if we have another major pandemic outbreak, we may not likely have a different result. So our health system model need to change in such a way that they also, all the health systems should be able to, the system should also focus on health security in addition to basic or primary health care. And it's a matter of, it's an approach that involves all of the society, all of ASAD, and all of the government. That is, government at all levels, they have to be involved in this. Also, it is time for us to strengthen cross-cluster integration and the mainstreaming of our programs. You know, while the presentation was going on, while it may not be completely strange, but it was a key information that was passed. Personally, I'm not working in HIV program, but I work closely with those who are working in the HIV program. I work in the emergency preparedness. And it is a major information that was passed that despite much progress that has been made, the young population seems to be left behind. And these are information that should not only be for those who are running HIV programs. These are information that should also be passed to those who are running other programs. So it is time for us to, but when we were having a meeting, we had a meeting 2 weeks ago, and the HIV team presented on the burden of non-communicable diseases that is increasing following the HIV intervention. And we were looking at how can we cross-link emergency, communicable, because resources seems to be dwindling with HIV program and other program, while vaccination, emergency have resources with them. Is it not the time for us to see how we can bring all the programs together and utilize all the resources instead of one program having too much resources, while the other program is not having any resource or little resources? And then at the end of the day, we will not, all of us will still remain at the same spot, because if this one is making progress and the other one is down, definitely the other one that is down will pull down the one that is going up. So it is time for us also in HIV programs to think of working with those who are not directly in your programs, for you to get not only the resources, but for them to also have the information that they need to be able to align their own planning to respond and make the success of your own program. Also, countries are not conducting risk assessment as they ought to do. And it is time for us also to have, I presume we have the plan, but in our programs, it is time to also start thinking, in case we have something close to COVID-19, what can we do differently? We don't need to wait till when COVID-19 happens again, because before we have a contingency plan, even for HIV program, for the next pandemic, because anything can happen in the current world that we have. And also, we need to also strengthen the support the strengthening of the surveillance system, particularly the event-based surveillance, which will help us to identify outbreaks early within the community. And also, we talk about the global solidarity and building stronger solidarity around data. And this is very, very, very important. Many countries all over the world are not transparent enough with their data. Why? Because of some of the experiences that have been seen in the recent years. And it is time for us as the technical team, while we want transparency to take place, it is also, there is a need for every partners, everybody to work together to ensure that data are managed and the integrity of data are preserved. And also the communication around data by partners and by countries should revolve solidarity. What am I saying? Last year when the Omicron, one of the Omicron variants came out, South Africa made an announcement of an outbreak of a particular variant in their country, and the reaction to that transparent action from South Africa was not good enough, which shows that the next neighbor or the next country that may have the next variant may not likely say anything. And that is why since that time we have not had much of any variant again, because the world also needs to build solidarity, not just in the treatment, not just in providing vaccine, also in solidarity around the data and how the world responds to the data that are given by transparent countries. And also, as I close, it is time for us to also improve the implementation of IHR 2005. WHO and partners, member states are working hard to review this and to strengthen this framework, the framework of this regulation, so that countries can be more responsive and we will not, so that we will not have the kind of experience we had in 2019, 2020 that was controversial, and the controversy is still on to today, how COVID-19 came up. We need a transparent world whereby if I am safe, you are safe. If you are safe, I am safe. We need to keep ourselves safe. And lastly, it is time for us to strengthen and utilize science and research and innovation to solve our problem. The world is changing, and we all need to agree and respond to the changing world. With COVID-19 and the threat from pandemic outbreaks, we all need to act fast, differently, timely, and it is time to invest in preparedness. When we prepare better, we respond better, and we save more lives. Thank you very much.
Thank you very much, Mr. Ayeni, for a very good presentation on emergency preparedness. I'm sure you have enlightened a lot of us about what is going on and how we need to be well prepared. We will allow 2 comments or questions to Mr. Ayeni before we can go to the next presentation. Karibu, Matthew. And then there's another.
Thank you. Mine is not a question. I'm impressed by the comment that we don't just need political will, but also the commitment. But I would add that we need to go further and talk about follow-up of implementation of actions against the commitments which are made. If I take an example of the AIDS Trust Fund, the government is committing money almost every year since the establishment of the ATF in 2015. But the trend in terms of the amount which is committed and the amount which is allocated and the one which is used to implement the interventions is diminishing since 2015. So it's not just commitment, but I would also advise that we put strategies to monitor and implement the commitments in terms of, for example, the allocation of resources. Thank you.
I'm so much impressed with your presentation. And I would just love to comment that your presentation can be one of the areas that we can identify to develop our advocacy plan for our community members so that we can be able to strengthen the systems. Yeah.
Last comments or question? Seems there's none. There's one here. Please identify yourself before you speak.
Okay, my name is Michael, coming from KVP Forum. I just want to understand more of, I wish you could talk more about strengthening cross-clusters integration, interclusters. What does that mean?
Yes, thank you very much. I think I can proceed to respond. Yes. You know, what is meant by strengthening cross-cluster integration and mainstreaming is, as we hear, now most of us that are here, we work mostly around HIV programs, which is communicable disease. But the effect of our intervention is linking to non-communicable, is directing us now to think of non-communicable diseases. And it was said by one of the presenters, which is a fact, that while people are not dying from HIV, or the proportion of death from HIV is reducing, but the burden of non-communicable diseases seems to be increasing. And it is time for, when HIV programmers are designing their program, it is time to think of the effect of their intervention on the population. While the scientists are evolving way out of improving the quality of intervention and the outcome, But the reality on ground is that the burden from the non-communicable diseases seems to be increasing. So you can't just be intervening, saving lives, whereas the same people are likely going to die of other consequences. So your thoughts you should start thinking, how do you don't just think, you work, you design your program in conjunction with those who are not directly working on your own programs. I also said that some programs have enough resources, while your own program might not have enough resources. Also, some programs don't have access to some of the information which they will need to plan. And the quality of their plan will also have impact. Because if I am aware now as a preparedness officer that more young adults are not making progress, when I'm doing my preparedness, emergency preparedness planning, I will also take note, because these are also vulnerable people in the population. So I will also take cognizance of that fact while we are recruiting or while we are designing some program and put them. So, but if I don't have those facts, I will just see those population as the normal population. So there are some of these that should be exchange of data, exchange of information, and the programming should work together to achieve better result, better outcome for the population. So that is what intercluster strengthening is all about. And also, for example, those who are working on disability, they are usually under non-communicable diseases. It is time to also mainstream many of them into our programs. Every program should work closely together, not in silos. It is time for everybody to work together, share data together, share resources together, and then donors have their priority. But sometimes the priority, most of the time, does not immediately reflect the needs in the community. So we that are in charge of program, when we have flexible fund, we can, for example, now COVID vaccination funding is a bit flexible. So we are encouraging those who are in that program to support those who are not, the program that are having challenges with fund, non-communicable and others, so that those burdens can be resolved together and we all make progress together. So these are what we are saying. Everybody needs to work together to achieve better results. We can't, if one is down, you can't prepare better. It is not possible. You can't have the best of preparation.
Asante sana, Mr. Ayeni. Thank you very much for a very good presentation. Can you clap for Asante? So our second presentation is from Mr. Michael Mhando, who is the Executive Director at the Center for Community Health and Development Research, and he will present on successful stories and prevention strategies from the field. Karibu, Mr. Michael Mhando.
Habari za mchana. Good afternoon, ladies and gentlemen and others. My name is Michael Robert Mahalo. They call me Tayaona, the last name. I represent Key and Vulnerable Population Forum, Tanzania. And of course, nothing for us without us. Sisi ndio hard to reach. They said that. Wagumu kufikiwa. But we are here together. So let us see. I'll talk about KVP Forum Tanzania. KVP Forum Tanzania was created to coordinate interests of all KVP Tanzania with the matters related to HIV/AIDS prevention, care, and treatment, and it was created in 2018, and this is because there was a need to do this. So the forum was there to make sure that this intervention, HIV prevention, care, and treatment are being implemented accordingly. Currently, KVP Forum Tanzania, we have more than 70 KVP community-led organization members in all regions in Tanzania. When I talk about KVP, I mean from the definition of Tanzania guidelines. We have guidelines which mostly centered on KVP, so let us refer from the definition. The forum was formed to support efforts done by technical working groups, which are coordinated by NCP targets in the CEA, and it works hand in hand with the government and stakeholders to implement 2030 national HIV targets, the 3 95s and 3 zeros. As you can see, there's a diagram there, shows how KVP Forum works and how it is cooperating with other people who are taking initiatives to make sure that this HIV prevention, care, and treatment intervention are being implemented accordingly. We have government over there, with IPs, KVP-led organization, healthcare workers, and community influencers, RSMGTs, CHMTs, and non-led organizations, USAID, CDC, UN agents, and healthcare workers. Also, there are visions and missions, as you can see. So why KVP Forum Tanzania? We want to make sure, or to ensure that Tanzania programs benefits, engage, and improve the health of all KVP, including underrepresented constituents. Yes, it is really hectic, thinking like we are hard to reach. So we thought there's a need, if these HIV and AIDS issues are being implemented and they see that they cannot get us, they cannot reach us. So the KVP Forum was formed to make sure these beneficiaries of these programs are being benefited effectively and improve their healthy and being presented by constituents. Also to make sure, to ensure behavioral change is taking place in public health perspectives, SBCC. We have challenge when it comes to implement public health issues targeting KVPs, especially behavioral change. Most of the IPs are forgetting that they are there for public health issues and trying to turn people to something else. We have seen this through the supportive supervision, which was undertook by the KVP Forum last year. People are receiving funding and they do something else instead of public health issues related to HIV prevention, care, and treatment. They do something else. We saw this and we took some initiative to make sure that they do things accordingly. It's not that every intervention that you are going to propose for a certain group of KVP will apply to the other group. For example, people who inject drugs cannot compare to men who have sex with men. You can take a person who injected drugs to a methadone and turn to somebody else, but you cannot change something biological to something else. We have transgender community. They are being forced to look like somebody else. So it's quite different. I've shown this, you can see the picture over there. The picture shows changes, a very big change. That is one person. That is one person. So if we have different kind of interventions, depends on the group, then we will achieve. So to provide coordination, we also, KVP Forum is there also to provide coordination at national and district levels. We are in different committees, and also we are there to provide, to make sure that KVP-led organization forums, we are advocating to ensure healthy and well-being to all KVP at all levels, from district to national levels. We've been going around Tanzania and through supported supervision and visiting district, and also we take the feedback to the national levels through Ministry of Health, and it's a part of it. We have some success of the KVP Forum Tanzania. These are just some of them. We have a lot. The forum was able to conduct supportive supervision in 16 regions in 2020, in 2021, 2022. In this supervision, the forum was able to improve program efficiency altogether. Yes, we did it. We're going through all Tanzania to see how the implementing partners who are targeting KVP, they are doing. Are they implementing their activities according to guidelines, or they are still creating some problems? That was the question we were asking ourselves. Are they creating problems, more problems, so that they can get more funding, or are they solving problems? That was our issue. So we decided to go through, and of course we discovered some issues around there. So in this supervision, the forum was able to improve the program's efficiency altogether. Of course, yes, there are some places whereby they say that the program is there targeting some, of course, some of the program. For example, you might find in a region there's a program targeting people who injected drugs. And they invested a lot, and they just left other, I don't know what research they are using or databases, so that they take a program at a certain place to another place. This is very challenging. Some of the places, the targeted groups are not there. There's other groups belongs to that place. So it was an issue. So to also, we have succeeded to coordinate different programs, including spearhead the use of KVP-led organization to receive and implement KVP-led organization. Yes, of course, through KVP Forum, through the commendation we did, more than 12, almost 15 KVP-led organizations have been trusted to receive fundings, for implementation from multiple donors, including PEPFAR and Global Fund. Also participating and lead in the core processes for all the civil society organizations, CSO in Tanzania, for 2 times in row. Yes, for some of the CSO who are in here, they might witness that we have been leading the processes, engaging other stakeholders, engaging other CSOs in different levels to make sure that the country operational planning is there to make sure that our needs are being included, and nothing left behind. Also, we participated a lot in parliamentary committees meetings in relation to a new, for example, this year we participated in a meeting. We went to meet our parliamentary committee. This is a selected committee on HIV, TB, and substance abuse We went, I think it was in April. So we went there to present our constituents, to present issues, and imagine, they said that we are politicians, we don't know anything. You just tell us what is going on there. We are not scientists, we are politicians. When you are in here, you leave everything behind, you are a politician. So you guys tell us what is going on. Of course, we had a chance to get invited again and again to tell the committee, the parliamentary committee, what is going on down there. Because there's a lot of politicians, they speak negativities towards the key and brown population, and this has been going on for quite some times now and distorts all of our programs. So we went there several times, and we're still going on to advocate, we're still going there to advocate issues relating to KVPs in Tanzania. Here you can see the pictures, the current head of prevention sitting with us on the picture and listening about what do we want to do more so that we can improve issues around there. So there are challenges, issues and challenges. I decided to group them into many groups. One is inadequate comprehensive programs, that is information awareness, and as well as referrals. Yeah, of course, we have these challenges relating to that on condoms, PrEP, PEP, HTC, STIs, and the other things relating to that. There's not enough education on what is going on. Most of the people are asking, what is going on? So what is our role to tell those people what is going on? Awareness, information is missing everywhere. Nowadays, there's a lot of stigma because of PrEP. If they find you with the PrEP, they say that, okay, you see, these are the medicine. These are the medicine for sex workers, MSM, and others. They don't think that they are also vulnerable people, because those KVP are not living in the island. They are our brothers, they are sisters, uncles, and everyone in there. So it's a bit challenge to see that there's low behavior clients seeking services, not only in urban, also in rural areas. Also, we have peer educators. Peer educators does not have a database of those hotspots, the real database. And because of some funding, sometimes they say that we have to do the mapping time to time, so we don't have funding to do that. Also, no refill of condom dispensers. We have a lot of condom dispensers in this country, everywhere. We have seen them. But when you go in that dispenser, there's no condom. No condom at all. So we are asking, where are they? I don't know who is taking, even maybe one person comes with a bag or something, taking all of it. We have to think about it. So preventive gears like condoms and PrEP be used as evidence by law enforcers. This is really bad. If I find you with a PrEP, condoms or whatever, I think for something else, that you are a criminal. Also, retention is not 100%. Retention is not 100%. compared to implementing partners targeting maybe target mobility or target mobility nature, lower treatment literacy for KVP in rural and rural areas, stigma environment of KVP living in both urban and rural areas. Yeah, we are moving. We are moving, yes. Mobility nature of KVP. Today, I might be here in the evening, I might be in Pwani, or I might be somewhere else. If you ask me a question, but why? Myself, I don't know why am I moving. I don't have an answer. Sina jibu why na toka hapa naenda pale because of my vulnerability. So because of this, we found that there's a law, this mobility nature sometimes depends on lifestyle we are living, but we are facing eviction from residential premises. Yeah, we are facing this eviction. Also, we are facing there's safety and security issues, self-stigma, especially transgender, the way they look like, the way they appear to you, they are facing, they cannot even access other services. Also, low treatment literacy to the community. So we have structure barriers, as you can see, there's a lot of structure barriers of HIV services uptake among KVP communities. As you can, we are because of mobility, transfer referrals issue clients who have been retention. This was found during the supportive supervision. Also limited safety and security for peers. Peers have been facing a lot of issues. There's a need for safety and security training to peers, in particular for those offering index testing. We all aware, we are aware about issues relating to index testing. Stigma and discrimination. Some of our healthcare workers are not KVP friendly, the extent that clients choose different facilities outside their areas where they're living. Sometimes they may shift even the region because of stigma, and it still is there. Unlawful arrests and ambush of FSW, female sex workers, MSM Pwili in the hotspots. You have already mapped your hotspots are there, but the ambush from maybe police officers, they might change your plan. So sometimes you might be, you should be flexible as much as you can. Using ARV and PrEP as by law enforcement as evidence, convicted the FSW, MSM transgender. I've quoted this. Ayatoeni Mabegieno, wote, ona dawa zao, hizi hapa. This happened in Iringa, I think. Yeah, it was in Iringa. The police entered their house where the ladies were in there, and they said, these are the sex workers. They said, okay, bring out your bags. If you are denying that you are a sex worker, bring out your bags. And they found them with the PrEP, ARVs, and other prevention gears. And they said, you see, these are the meds. They are being given by their organizations. So this has been challenging. So we have some few recommendations to undertake comprehensive legal desk review with the inclusion of community and all multiple stakeholders from PURAG, Law Enforcement Unit, and Ministry of Legal Constitution, even increase the sensitization meeting. This is the sensitization meeting. We have to do it a lot. I know Targets has been there. They were doing a lot of things relating to that, but still there's a problem. Linking KVPs with KVP with existing KVP toll-free report, gender-based incidents. Still, we have to work together on this, and implementing partners should collaborate with the KVP forum in addressing these challenges when it occurs in their areas of implementation. sometimes working with KVPs, some of their stakeholders, they're thinking that if they work with us, they will be taken as they are promoting something, like they are promoting homosexuality, like they are promoting like business of female sex workers. But I don't know, maybe they need to dig deep and think about how they can work together with us. Administer training on how to support GBV, SOG, sexual orientation, gender identity and expression, and IPV to both peers, healthcare workers, to put in place a friendly system, also support GBV experienced team. KBP Forum to conduct a case study on law enforcement and harassment. Yeah, of course, there's a lot of harassments going on, so we are thinking, how are we going to get there? The 95 and the 3 zeros is a big challenge. Also, lastly, to sensitize all the identified key actors from PROLAG, law enforcement unit and society, issues relating to human rights issues, law interpretation and gender-based violences, as a sex worker are human beings before sex workers. Thank you so much. Thank you. Thank you.
Thank you very much, Mr. Mhando, for your presentation, and you have, I'm sure, created some awareness for people in the room. So, because of time, and we are supposed to go to panel discussions, I think we can, and you are one of the people that are going to be in the panel discussion, so we will allow the panel discussion to begin now, and if you have any questions or issues for Mr. Mhando, we can address them during the panel discussion. So, we have 5 panelists that are going to discuss different issues regarding how to re-accelerate existing prevention measures and integrate innovation prevention measures. And our panel moderator this afternoon, our panel moderator this afternoon is Mr. Daud Nassib, who is a co-founder and consultant Beyond Health Tanzania. So he's going to lead the panel discussion. Karibu sana. Karibuni, I will mention the names of the panelists wakati Mr. Daudi is sorting his life out. So we have Mr. Michael Mhando kama hivyo ameshakaa from KVP Forum. Alafu we have Innocent Grants. Innocent Grants ni yupi? Innocent Grants from Young and Alive Initiative Tanzania. Okay, that's Innocent Grant Magofi. And there's PLHIV representative Cyprian Komba from Network of Young People Living with HIV, Komba. And we have, we have Dr. Wana Maukola from the NACP. So we will allow 7 minutes for each of the participants, for the panelists to speak, so that we can have enough time for discussions. Karim Sana, mic to Mr. David.
And for timekeeping, do you want us to help you with showing the signs, or will you? Yes. So speakers, kindly feel free to be looking at us as you speak. We will be alerting you on time.
Thank you so much. We have had a fantastic session this morning. I just want us to stand up we just want to stretch a bit before we move to the next session. Can we do that, please? Just stretch yourself. Take in oxygen, feel good, and be ready for a much more exciting session and discussions. Okay, thank you so much. I am very happy and pleased, and I welcome my panelists here. I will start with taking home some of the issues that we got from the morning discussions when we started today, and we learned that to be able to achieve the epidemic control, I'll be slow here, to achieve the epidemic control, prevention programs need to be more effective and faster. We need to do that. We're already doing very well in the treatment section. So what would putting communities at the center of the national response mean, for example, to the PL-HIVs and the young people living with HIV and AIDS and the general population? So I'll start directly with Innocent. Just what would this mean? Because you know we've talked about putting people-centered approaches, and we've seen that it is very important to ensure that for the epidemic control to be achieved in Tanzania, we need effective and impactful strategies. So how do we do well to reach the young people?
Yep. Thank you so much for this great question, and I think we are. I was talking to one of my colleagues outside there, and I said I think we are doing really great, bringing all people who are working around HIV/AIDS intervention in Tanzania in one room to kind of learn and find ways to collaborate and doing partnership in order to bring an effective response towards HIV/AIDS in Tanzania. Now, before I respond to this question, ways to accelerate existing mechanisms and innovation to end AIDS in Tanzania, I want to reflect back on the history of HIV/AIDS just a little bit to understand where did we go wrong. Until to date, we have a burden of more than 40 years, dealing with one pandemic, which is HIV/AIDS. And when I reflect to that story of where did we go wrong, the simple answer was stigma. Stigma was what allowed HIV/AIDS to spread across the world. Non-government organizations failed to do effective response. Governments failed to do effective response. The people who are working around research failed to do effective response to the HIV epidemic when it was during at the earlier stages, just because of stigma, and it's because they thought HIV/AIDS belonged to the certain group of community and doesn't belong to the other group of community. Where are we now? It's more than 40 years. We have the pandemic uncontrolled. Up until today, we're still speaking on how to reach all community members with right interventions. We have saw from different data that have been presented today. We are still lagging behind in some groups of the community. So today, the way I see it, and even this it came to manifest itself during the COVID-19 pandemic, you could see the kind of discussions that are coming up during the COVID-19 pandemic, during the COVAX rollout to the communities. Still stigma was still there. So I want to say the best way to accelerate innovations, to accelerate response towards HIV/AIDS, I think we need to get back to the baseline of humanity, understanding that we are all human beings, and disrupting the culture within the community that discriminates some groups of the community. The moment you have a community that discriminates a certain group of community, is the moment you start creating an oppressive and a general, discriminative community that way. So I think we need to come back to the humanity and understanding the needs of humanity. So whenever we are designing HIV/AIDS response programs, we should be responding to the needs of the community. Now, I just wanted to reflect back on that history, that stigma brought us to the really hard situation today. And I think within our programs, we really need effective mechanism to address stigma, effective social behavior change mechanism to address different harmful perceptions and norms that are within our communities, not just within our communities, even within key actors in the room, as people working in non-government organizations, people from the government. We still have stigma. That's why sometimes we come up with non-responsive programs within the communities. We think this is the right intervention. We try and say this intervention is going to help this a certain group of people, while we are also forgetting other groups of people. And then the second thing that I want to say, I think we may also need to start designing programs while building on the existing community mechanisms. For instance, I'll give an example. Most of our programs, I'll give an example, let's say from the Young and Alive initiative, where I'm coming from. When we come up with new programs and then we go to the community, sometimes we tend to say, you know, I went to Mtwara and find maybe the culture of Gyando and Bunyago. So we go there and say, you know, this is a bad culture. We need to eliminate all of this. But sometimes that creates a backlash and makes the new program that you're going to integrate within communities not having a greater response. Sometimes we may just need to acknowledge what is already going on in the community. So let's say instead of disrupting Gyando and Bunyago culture, telling the communities, we know you're doing Gyando and Bunyago, that's fine. But to make Gyando and Bunyago more effective, you know, Gyando and Bunyago, which could not accelerate HIV/AIDS, we need to integrate these kind of discussions within the Gyando and Bunyago culture. So building upon existing community cultures and, you know, its own community cultures and interventions. If the communities have a tendency of meeting every day morning, meeting with their traditional leaders, let's go and meet them there and stop saying, you know, we don't want you to meet with your traditional leaders. We don't want to do these traditional gomas because they accelerate HIV/AIDS. No, but build our interventions within the existing mechanisms that the community are already doing within the communities. I hope that's a good start. Thank you.
Isn't that fantastic? And I just want to remind you that our session, our panel discussion topic today is how to accelerate existing prevention measures and integrate innovation, and this has been an excellent connection to that. I'll go directly with the same question to the gentleman who just spoke here before we move to the next, and that's Mhando. Mhando, using the same, building on the same discussion on how we are able to implement human-centered approaches and bring in and engage effectively the key and vulnerable populations. What more can we do that we haven't been able to do before? 2 or 3 minutes.
Yeah, thank you. My name is Michael, and I introduced myself. Meaningful engagement. We need to be engaged effectively, not partially, effectively from the beginning. Kuanzia mwanzo mpaka mwisho, from the beginning, from the designing stages. Ask us, because there's a time we were asking ourselves, okay, you are designing something based from the people you invited from Dar es Salaam. They will tell you things from there. You didn't invite people from Kigoma, from Mwanza, from Ruvuma, from other, and you are thinking that there's no KVP there. Who told you that? Okay, you are designing something, a policy or kind of something that will last maybe for 6 months or a year, and not for the rest of the years not applicable. And it's because you didn't engage us effectively. You didn't call people from diversities. Okay, you are representing, you are inviting people to make a kind of policy, but you are taking only one person and you are saying that this fisher folks, according to the definition, will represent transgender. How? We represent MSM, we represent sex workers. How comes? So we need meaningful engagement from the beginning so that we can make sure that, as the topic said, we achieve from the scratch. We are being engaged from the beginning. STIs nowadays is a problem. It's a challenge among the KVPs. But we all, our eyes on HIV. there's those risky stages that STIs, whoever having STIs is really likely to have HIV very easily. Why are we waiting for HIV? We are waiting for HIV and not taking those precautions from the beginning. Kindly, we really need to engage to engage us. You need to engage us to tell you what to do, to tell you about us, tukwambie kuhusu sisi, not designing something which it's even not related. Please take that away, take that negativity that KVPs are originating from Western. They are saying that we are originated from somewhere. No, we have KVPs of 70 years of age, 70 something, 80s. We have our elders. Please, kindly let us, invite us, we'll tell you what to do. Thank you.
To handle, and he's emphasizing anything without us. What did you say? Anything without us? There's nothing for us without us. So it is very important for them. It is to ensure that there is meaningful engagement, and we've taken that message strongly here. And I'm going now to move to Komba Cyprian. And with Komba, I would like him to take this discussion further into how innovatively can we reach young people. We've seen that among the challenges that we have that has been emphasized is our inability or ineffectiveness to change the trajectory, especially on the part of the young people. How can we use innovation, digital, and other emerging technologies to reach more young people, to engage them effectively and put them at the forefront of the HIV prevention?
Thank you so much. I'll just be building from what my predecessors have talked about, and I'll talk around on the issue of ethical and meaningful engagement of young people in the HIV response to accelerate the response. As we know that as young people living with HIV, first we are proud of the significant progress made in HIV treatment and care, and however we are convinced that the elimination of the new HIV infection can be accelerated if the organizations, donors, government agencies, and everyone working to end HIV/AIDS partner with us meaningfully and ethically. And as young people, we have identified the things that matter most for us to accelerate the HIV response. And those things, we say, like, first, you need to keep us safe. And on the issue of keeping us safe is looking around on the issues about how as a spaces created for us, that we are able to communicate and just talk about the issues that are going on within us. We are free, and then we can feel safe, and also we can give more. We can just provide insights and also provide maybe a methodology that would help in preventing new HIV infection. Number two, for us young people, we said, like, we need to value the contribution of each young person. It happened a lot when the organization working with us to accelerate HIV responses, they are not valuing the contribution of young people. They can pull us to become the part of the meeting, they can bring us to become the part of the design, but whatever we're giving out, our innovations, our idea, and what we think should be going well, they are not incorporating it in the whatever, when the final drafts are coming out, our voices are not being found across whatever anything. So this is an ethical engagement of us young people. Thirdly, we said, like, we need to ensure diverse presentation of young people. We as young people, we belong from the diverse group. As young people, we are belonging from, among us, we are living with disabilities. Among us, we are coming from the other ethnic groups that are not really being emphasized in the country. So working together with us and making sure that we provide impactful information to accelerate the HIV response. Every organization and everyone working with us must ensure that there is diverse representation of young people. Fourth is providing support to young people. It happened a lot when you ask the organization working with us to accelerate HIV response that why are you not ethically engaging young people, or you're not bringing young people in the planning, implementation, monitoring, and even evaluation of the programs. What they end up saying is young people, they are not knowledgeable. But as an organization, as a donors, what are you doing to empower these young people to be able to understand how can they navigate best, and how can they do the things like the way you do? Because we are the future and nobody can stop us. We have to be there. We have to fight for our future. And the other thing that we thought it's very, very important is building positive relationship, positive use relationship. You as an addict, you as an organization working to accelerate HIV response, it's now a time to look around things like making sure that you have created a positive youth relationship, that me as a young person belonging to the network of young people living with HIV, the other one is working with the other, maybe like Innocent working in another organization. How are we together congesting our effort to accelerate the HIV response? But how are you supporting us? And how are you supporting young to promote a greater accountability among us young people? Because these issues of an ethical and a meaningful engagement of young people store the HIV progress. And the reason behind, because as young people sometimes we feel like we are not the part of the part of the campaigns. We are not the part of this movement because we have not been ethical and meaningfully engaged, while we continue to bear disproportionate burden of the HIV globally and even in the country. So on my side, I do believe that we can end the AIDS by 2030. But the curve cannot go down by itself. We need an effort to pull it down. And how do we need to pull it down is like bringing everyone, making sure that the voice of everyone is there to accelerate the HIV responses. That we provide a methodology that we think this design, this model, this intervention will work best for us. And as young people, we want to be a subject, because we continue to bear the disproportionate burden of the disease rather than being an object. Because it happened a lot that we are being seen as an object, not a subject. And also, you have asked the issues around how can we use the media platform, the media platform to accelerate the HIV response. It's now the time to make sure that we empower young activists to take lead of the HIV responses. We have many young people who are able to tell their stories. They're able to disclose their status in the aim of, with the main aim of providing education and knowledge to other peoples, to understand how it is difficult maybe living with HIV. And so that those who are negative can continue to stay negative, and those who are positive can retain on care. So how we need to make sure that we empower these young people to be able to understand the advocacy spaces, to take the lead of advocacy, and also create awareness using their social media platforms, putting an hashtag to the organization, fellow young people across the country and everywhere, to understand that this is what is just going on, and this is what has to be done, because they have their own lived experience. And lastly but not the least is looking around the issues of making sure that we capacitate the youth-led organizations. It happens a lot that there are youth-led organizations working with young people, but they have not been capacitated. They cannot know how to intervene best, and then we still take them as the numbers, and then we have these 3 organizations working with young people, just their numbers. We report them, we put there on the presentation, but how do we partner with them, and how do we support them to accelerate the response should be the question to us. Thank you so much.
Asante sana. This is wonderful, and can we also give them another round of applause? Dr. Makola, you heard the gentleman here. He just told us that young people they're not a homogeneous group of people. So when you involve young people, it's not a matter of numbers, that we have 3 young people involved here, so we got everybody. They have different needs, they have different desires and ambitions, and they have positions and vulnerabilities. I know you once talked about differentiated approaches in provision of services. I would like you to expound on how NACP, the government and partners can provide this approach to be able to reach and to bring together those that have been left behind. Without them, we will not be able to reach the epidemic control in Tanzania. Karibu.
Well, thank you very much. Just to begin and keep everybody on the picture, I'd like to give a very short definition of client-centered approach, which was defined by one of the partners. So in this definition, client-centered approach in HIV is bringing service to those who need it and the way they want it. So very short. So going to that, I will base my discussion by dividing my focus to three groups. One is the government of Tanzania, what is the role they should play in making sure that client-centered approach in HIV is achieved. And the other part is our partners, our implementing partners, everybody who is rendering service to HIV in HIV response. But thirdly, the clients, in this case, the key and the vulnerable population themselves. Going into the government, I think one of the speakers, there were two actually preempted me, but we all understand that our primary role is to develop and make sure that whatever is implemented is according to guidelines, standard operating procedures, and so on and so forth. So it's upon the government of Tanzania, and I'm sure this is well done, but there might be some places where we need to pull up our socks to make sure that whatever we are planning in those policies, in these documents, actually reflect what is needed in those populations. So this, again, echoes to what was said by a previous speaker, that we need to involve people with the right people in developing such policies. Again, on the side of implementing partners, in maintaining or making sure that we have client-centered approach, for them as well, they should respond to the needs of the clients. I can cite one example. We all know that and we have heard in the morning, that most of our services are depending on donors, and what we are actually responding corresponds with what the donor wants in responding to the grants we are writing. But we need to be crafting our proposals in such a way it responds to the needs of the people while responding to what the donor wants. So we shouldn't just write things just because somebody wants us to write. So actually responding to the needs of the community we want to serve is very important. Again, on the side of partners, there's always a conflict or the difficulty in implementing activities, because we know that funds come with conditions, we have targets, but sometimes it happens that people may compromise the quality of services at the expense of numbers. So this is very serious, and we need to be very careful while we are implementing our services to make sure that what we are implementing actually has an advantage to the clients while responding to the need of the donor. Again, on the partners side, I think we need to understand cultures. this may also apply to the government side. We need to understand each part's cultures. For example, for those, I can cite one example. There was a person who was actually working for a partner and later worked for the government. And when that guy joined the government, he told us that I thought you people are just delaying things because you want them to be delayed. But I know now how the process is and how things should happen. So I think sometimes we may blame a person that things are not happening, but there are procedures in each part, in each organization. There are do's and don'ts and how the things should go about. This can be well referred to. For example, a change of any law may take quite some time. So both parties should understand that this is a process. It's a very lengthy process. So, and we all need to work together for something to happen. So we should understand each party's philosophy and how they work. But on the side of key and vulnerable populations themselves, I think we very much need to understand and take note that stigma is also among us, among the key and vulnerable population, and we need to deal with it. Taking everything negative may also makes things worse. So I know stigma is on both sides, and we have been informed by the previous stigma index. So it's on the client and also on the side of other general population. So everybody should take part in making sure that stigma is dealt with. And for the key and vulnerable population, again, it's for them also to understand what other people, what other organs are also working, referring to the government as well as to implementing partners, as I said previously. So from my talk, you can, what you can gather is that every one of us has a role to play in this. So if you want to go ahead and have what we want to achieve, which is epidemic control by 2030, we need to join hands and understand what each party's role in this fight. Thank you very much.
I think we can do better clap than that, can't we? Thank you so much. That's very, I think it was very fitting for you to be the last one in my panel here. And we have had this call that to be able to reach everyone, we need everyone. Everybody needs to play their part. We have a role, each of us. Ladies and gentlemen, I would like now to move this discussion forward to you. And I think we have, Chairman, we have saved some time here, a few minutes, so that we can have much more discussion among our participants. And if we have any question, any follow-up issue, we're trying to move away from, you know, we've been told that our response is in danger. We've been given evidence that we're not doing well towards the epidemic control, but my panel here has tried very much to put together ideas in terms of how we can improve, bring those that have been left behind, and other strategies that are inclusive, people-centered, and be able to make progress. So if you have any questions, issues, we'll start with the lady over here. Please be direct so that we can all have opportunity to speak.
Okay. Thank you very much for this opportunity. My name is Amina Harry, and I'm representing UNFPA, and I work actually on the Central Reproductive Health and Young People portfolio. So I just have a few issues like to add on what has been presented from, and also based from the government. I think we do have a lot of documents that are supposed to guide us in the prevention as well as treatment. Recently, I think last year, we launched the NAIA document that is talking to the adolescent girl and young people. And in that document, there are lots of issues on HIV as well. So a lot of the work to do is on implementation. We don't need to come with anything. We have to really focus on implementation of the strategy that we put forward, and will bring changes. But I also think we need to also get back to a national HIV campaign. At some point, we used to have these very big campaigns countrywide. I think to go back to that so that we reach majority of the people. But we need to bring HIV back on the agenda as it is for COVID. At some point, we used to go, HIV is on each agenda. Whoever speaks, we speak of HIV, but that is gone. So we need to bring that back. As long as the way we put COVID-19 on the agenda, we need to revitalize HIV and put it on as a national agenda. But as far as the young person talked of meaningful engagement and bring everybody on board, but as we saw, studies still show that adolescent girls and young women and women in general are bearing the brunt of this epidemic. So in all that we do, the adolescent girls and young women need to be at the core and at the center, because they are the ones who carry the heavy burden. So no matter how much we involve the other groups, but the groups of women and adolescent girls need to be at the forefront, because in the end, they are the ones who are seen have the highest burden, especially on the new HIV infections. But as we saw also, comprehensive knowledge on HIV has gone low. So I think the emphasis also goes back to bringing comprehensive sexuality education in schools. Like young people need to understand from a very young age on CSE, how to take care of themselves, how to be assertive, and for some reason they need to have this education. So emphasis on CSE in schools. But then again, availability of the protection gear, particularly on condoms, they need to be available, they need to be accessible to all adolescent and young people who need them. They need to be available. And especially for condoms, as we do them for triple protection of HIV, STI, and also teenage pregnancies, which are also exposed young girls to HIV. But at the same time, involvement of people with disability, they are most of the time prone to rape, and they might get infected. But also addressing gender-based violence is part of combating HIV as well, which might be a reason for new HIV infections. So just to add on that.
Can you go next? Finish this side and then we'll move to the
Okay, thank you. I'll be going very short. My name is Evans Ngei. I work with Bella Tanzania based in Kigoma. I have a question to Mr. Mhando and the Komba CPN. The first question is, you have said that you've talked with the member of parliament several times. What are your success thus far? The second question is, apart from donors, outside donors, does the government of Tanzania provide some support to promote the KVP services? Okay. The question to Komba Cyprian, you have said, I prefer what you said. You said that there are many young people there ready to disclose their status through social medias. Don't you think that disclosing their status in the community where discrimination is high, you're exposing them to discrimination? Thank you.
Let's move to the lady here and then we'll, excuse me. Right. So let's be brief and direct and then we'll move fast.
Thank you. My name is Noela Nsanzugwanko. I work with THPS, Tanzania Health Promotion Support. We also work with key and vulnerable populations, so I will direct my question to Mike. Thank you for a very good presentation and well presented. My question is, we are facing a big challenge about mobility of key and vulnerable population, as you said. So what are your suggestions? What interventions can you suggest we can put in place so that while the key population are mobile, while they continue with their economic activities, they don't interrupt their treatment? I'm referring to ARV and PrEP. Thank you.
Thank you. Dr. Lillian Benjamin Mokiosi. I lead an organization called DARE. I'm an AVAC Fellow 2018, but also IAS Differentiated Care Youth Champion for the year 2017. And speaking of DSD, my question will be going directly to the panelists from NACP. Clearly, from the presentations we have had throughout the morning, the lives of young people remain at stake, especially young women when it comes to new HIV infections. And we were also told that condom use remains very low, not just amongst young women or rather young people, but the entire population. So clearly we can't be relying on just one tool to prevent or end up controlling the epidemic. And it tells us that choice remains critical when it comes to HIV prevention. And what I would like to understand, speaking of innovation, integration of innovation in HIV prevention, what measures are currently in place from the ministerial perspective to making sure that we fast-tracked the introduction of new HIV prevention tools? We have newly approved biomedical HIV prevention tools like the dapivirine vaginary, which is the first ever discrete long-acting HIV prevention method that is specifically designed for girls and women, but also we have the long-acting cabotegravir. I would really love to understand what measures are being put in place to making sure that we're able to accelerate access, understanding that approval is not yet somewhere we have reached at. I would really love to hear if there are any plans at the ministerial level to make sure that we have implementation silences in place and save as much time as possible. By the time we have licensure in place, young women, girls, women can access these tools as soon as possible. Thank you. And it will be great for next time to have a young women face on the panel.
Thank you very much for the very good presentations, and I have two questions. Actually, Noella preempted my question that I wanted to ask. The first question goes to Dr. Wena. Dr. Wena, I know we have a lot of things which have been done for the key and vulnerable populations, like a stigma index that reports us we have community-led monitoring and issues like that. So many things have been done and so many reports that we have. So the question is, how are we with implementation of what came in from these things that have been done? Because I see a lot of people coming and saying, we need to do this, but there are a lot of things that have been done in the community-led monitoring. Probably we need to see how are we implementing and how do we monitor implementation of these recommendations. So the second question was, like Noella wanted to ask a question, but my question is, Michael, if you can tell us just for like a short-term intervention, what should we do for the PrEP, especially for the PrEP, where we see a lot of movements and we don't have, especially when we are talking about retention and the PrEP current, and we don't see people moving, and we always lose people. But can you tell us for the short-term, like a short-term intervention that should be done for this one? Oh, thank you.
I think I shouldn't have let you speak before me because you took some of my questions. But just to add on to the question around data systems for PrEP, we've heard a lot about performance in HIV prevention and treatment, but we haven't heard any numbers on PrEP. And as we're talking about expanding the package of services with new interventions, as the previous speaker said, it will be good to know where we are now with the interventions that we have, particularly with tenofovir FTC, which is already approved in country, I'd also like to hear more about the plans for approval for Kabele as well as the February Ring, as well as any other PrEP interventions. But also something that keeps coming up is around data systems and tracking for PrEP, in particular the discontinuation part. I know that colleagues from the KVP Forum and CSO had talked about it, but I'd like to hear from NACP as well, how they're dealing with that, as we know we don't have a unique identifier for PrEP. Maybe we do, I'm not sure. But I'd like to hear more about how we're working on that. Thank you. And I would also like to add that we should have a young woman on the panel next year. Young women's.
I think let's stop here and now we take responses. I'm sure the organizers have seen it. Even myself, working in the gender field, coming in front here, I noted, but I know people represent issues, not sex, so I take comfort in that. From NACP, I know it's mouthful, and I will need to protect him. He will not be able to bring everything off the cuff, all the reports, all the updates, but I think he will do justice just to give us the trends if something is actually being worked on. Can you get us started with the responses? Let's be brief. I'm warned that our time is very limited.
Thank you for follow-up question. One from UNFPA. Yes, we do have these developed documents, and it's upon all of us to make use of them, not only the GOT, as I insisted earlier. So if there's anything you can tap from these documents, every one of us is a champion in those documents. Second, on HIV agenda, I think this is reiterated now and then, and we have somehow forgotten to speak about HIV, and young people being born now, they need to hear more. It's like the information has been saturated, but there are people who do not know many of the things. Thirdly, on inclusiveness, yes, we need to include those who have new infections most, but I should warn everybody in this room that we also need to include men, because if we insist on young girls, where are they getting HIV infection? We should ask ourselves. So we shouldn't disturb this ecology. We need to also focus on males. Dr. Lillian, thank you for your observation on new infections around young people and the developments we have, including injectable PrEPs and the DPV rings. As I insisted earlier, there are procedures in absorbing new technology and steps. We have heard about DPV ring and also the injectables, and we are following it up. We are not sleeping. On community issues, I should speak of these two things separately. There are interventions within the community, and new information is there. So what you are calling is absorption of these new findings or innovations to improve our services. I think this is again not only for the government, but for all the partners to take what is relevant to them. Again, on the community-led monitoring, this is very important to note that we I think NACOFA is starting soon to have community-led monitoring. This refers to like questionnaires or protocols or questions being, or investigation of our services, but the initiative comes from the community. It's not from the health facility or the government side. It's from those who are getting service to question those who are giving services. But it's not well developed in our country, but it's coming soon. Lastly, on PrEP data availability, we have PrEP data, but as the moderator has said, I can't have numbers yet, but if you want them, they are available. Again, on the absorption of new technology. There are procedures, and we have taken them on board, and if they seem to be useful in our country, you will see them being advocated. Lastly, on making sure that there's a continuum of care among the KVP, especially on PrEP. There's lots to follow up. It's not only on PrEP, with most of the service being delivered at the community level. So some of you may have heard about Unified Community System. This is an electronic-based system, and we have just started to design this. We will use tablets right from the doorsteps, right from the communities. So community healthcare, community providers will be given tablets, and they will enter data from the community right into the tablets, and it will go up on real time. So PrEP, AGY, HIV testing, and other modules will be there. So people will be identified by using unique ID, and later on they will also opt for biometric for each of us. But we can also use driver's license, national ID, and so on and so forth. So unique identification is coming, and soon you will have tracking of every service being done, not only from the community, but also from the health facility level, and for all services, not only HIV, for all services. Everybody of us, we have been identified by using a unique ID. But that is a development to come in several years. Thank you.
Thanks so much, Dr. Wana, and he has also helped us to touch on the comments that were given, so my other panelists will concentrate on the questions very directly. Please, Karim.
Thanks. I think I didn't have any direct question to me, but I just wanted to build up on the comments, just one or two. So for instance, representatives from the UNFPA mentioned about the importance of sexual productive health education to young people. I also want to emphasize that. So for instance, the government last year launched the National Accelerated Investment Agenda for Adolescent Health that wants us to provide, to reach young people from their area, adolescent age from 10 years old, with right information on sexual productive health and rights. The only thing that I normally find is we don't want to acknowledge that young people are doing sex. Now, we have to acknowledge it and then bringing them with right information. Also, building up on my previous comments regarding building our interventions on the existing systems, that sometimes you tend to see them as bad, but they are working. So for instance, in Tanzania, tunapenda kusema bongo flava ni mbaya, inaeneza matusi, inaeneza lugha mbaya, inashawishi vijana kufanya mapenzi. And then we want to disrupt that to bongo na flava. But what we did at some point, we had to decide building upon the same music generally. Tukaanzisha kitu kinaitwa bongo na flava. Tukatumia bongo na flava hiyo to bring right information on sexual productive health and rights. And young people listening, wanasikiliza. And then the last thing, speaking about innovations, innovations in social media, change communication, innovations to reach young people, innovations to reach, sometimes we tend to think innovation is kind of complicated technologies, but where young people are really found, most of the young people utawakuta kwenye really simple social media platforms such as Facebook, Instagram. How do we really bring right information in front of their faces using those existing platforms? I think it's something that we need to learn. Na tunaweza tukajifunza from one of the practical example regarding one of the practical example that provides pleasure-based sex education and provides right information on contraception and sexual productive health inaitwa Tuongeze Sompango. It's just a Facebook page where young people are really leveraged and then they get to learn right information. And then the last thing is about stigma. Stigma, tunazungumza sana. We speak a lot of stigma. Stigma towards key vulnerable population, stigma towards minority groups within our communities, lesbians, gays, bisexuals, transgenders. Now, sometimes the best way to alleviate stigma it starts by us within these rooms. Mimi nimechoka kutana people who are working around sexual productive health, working around HIV/AIDS intervention, and kwanza wana homophobia, they spread a lot of hate kwenye communities, and at the end of the day tukiingia kwenye hizi rooms wanasema we have to alleviate stigma. Inabidi we start addressing stigma among ourselves. That's the best way to kumbukizana jamii kwa ujumla. Thanks.
Thank you, Stephen. Wave.
Okay, so 1 minute. Responding to your question about the disclose of the status, I understand that this status is the process, is not an event. As young people, I was talking on disclosing the status on a cause of helping to provide knowledge and maybe providing awareness to other young people. We have young people who have been trained. They have been trained to understand the risk of disclosing their status and also the benefits of also disclosing their status. And they have took view by themselves, they have decided to disclose their status. I can stand up on a t-shirt written ready. This is a short form of resilient, empowered adolescent and young people. So these are young people who are resilient, empowered, and they are championed to support fellow young people.
1 minute.
Yeah, of course 1 minute. The general answer, kindly work with KVP Forum Tanzania. Ndio habari ya mjini. Right? If you don't reach the people you are targeting in your proposals, kindly reach KVP Forum. We have KVP Forum in Tanzania mainland and we have KVP Forum in Zanzibar. The chair of KVP Forum Zanzibar, can you stand up and raise your hand? You, Omar. You are in Zanzibar, you're the KVP, chair of KVP Forum. We have Marinels there, KVP Forum chair in Tanzania mainland. So kindly reach us, we'll tell the secret. Tutakueleza siri ya mafanikio, right? Yeah. So, yeah, and the other thing, Dr. Lillian, I'm joking. You never know, there's women here. Thank you so much.
A light moment. Chairman, chair, you say chair lady, chairperson. Oh, okay, chairperson and everybody else. I want to thank you all for very active participation. This has been an excellent session. My panelists here, they've been excellent. Time is always limited and limiting. And therefore, we have taken a lot. There are questions that have been risen there for us to think about, to help us through the process, continue thinking when we go to the next sessions. So it doesn't end here. We have just started rolling the ball. We hope to be much more productive next time around and bring more issues in the next sessions coming from this time. I thank you so much and see you next time.
Mr. Nasib and your panel, can we have a clap for them? And also for all the people that presented during the morning session, we are very grateful. We have really learned a lot. So now we are going to break for lunch. But before we go for lunch, we will have a group photo and we will be directed as to where the group photo is going to take place. And also, we are also encouraged to select questions. I don't know whether people have done that. We're supposed to select questions for group work that will be done in the afternoon. So please kindly select the questions that you would like to address. So you select a question before, so that by the time we come back, you know where you're going to be seated. And also, we are told that the photo will be done outside, I think downstairs.
Yes, downstairs.
In the podium, downstairs, yes.
Podium. And we come back at 2:30.
Yeah, we come back at 2:30. Asanteni, pigeni makofi.
you would agree with me. We have regional differences, and we are soon getting new updates on the prevalence. This is from population-based survey. It's not from our data from the program. So as of June 2022, we have 6,000, close to 7,000 as facilities offering HIV care and treatment service, and estimated pure HIV from the modeling spectrum is 1.7 million. Those who are currently on ART was 1.5 million, and the first 95 was close to 92, the second one was 99, and the HIV viral load was suppression. And this is from those facilities with the electronic database and excluding those without an electronic database. But they almost reflect the reality because it's close to 95% of all the clients we have are on this database. So regarding, I've chosen only some of the interventions. One is the test and treat. We all know we started in 2017. If you are found to be positive, regardless of the CD4 and the other criteria which were used before, you kept on ART. The other intervention we started is same-day initiation, and in our context, same-day initiation means it's ART within 7 days of enrollment into HIV care and treatment. And we also have multi-month dispensing. We either have 3 months or 6 months, depends on the different parameters, including availability of drugs. So the graph actually shows how we have been flaring from 2021 to 2022. You would realize we have up to 95% of our people getting same-day initiation. So we are close to 100% of all PHIVs enrolled in care starting treatment within 7 days of the enrollment into the clinic. I think this is a very big achievement. The other thing I would like to mention is about advanced HIV disease. We know we have adopted a categorization of clients into early disease and advanced by using certain criteria. And if you are found to have advanced HIV disease, you should get this battery of services, including screening for HIV, for TB, sorry, providing TB preventive therapy, and taking care of cryptococcal disease, cotrimoxazole, and other risk counseling. So if you look at the graph there, shows about TB preventive therapy, how we are flaring, and you'll see the numbers there are encouraging. So that's the progress in that area. The other thing I wanted to share with you is ART optimization, and this means keeping patients on potent medication. And in this way, in this aspect, I'll talk about DTG. DTG 50 for adults and adolescents, and the DTG 10 for pediatrics. And we know the advantages of adopting DTG, and one of them is tolerability compared to lopinavir, boosted lopinavir, because before this we were using boosted lopinavir for children, and it was not very friendly, and some of you may remember they had to crush tablets, put them in the food, and it was very cumbersome. But for DTG10, which started in June 2022, it's dispensable. You put it in water, and it's very palatable, it's sweet, and the children will like it. Again, DTG is less toxic. It has a good genetic barrier to prevent from mutation for the mycobacteria, or for the virus, sorry. So if you look at how we have moved our clients from those old regimen into DTG-based regimen, you see we are close to 100%, but we still have, for adults, for example, we still have people on TLE, which was a prevalence-based regimen, because some of them refused to go into DTG, and especially for pregnant women and childbearing women, because of the, at first it was said that DTG is not good for childbearing women. And some of them diabetes or any other metabolic disease which may be worsened by DTG. So they are still on old regimen, but most of them have shifted into this regimen we think is very potent and is efficacious. Lastly, about HIV treatment monitoring, I would like to speak about HIV viral load. This is data April 2022, May 2022, and June 2022. So this is coverage, coverage in the sense that among those who are due to HIV viral load testing, how many have tested for it. So we see the proportion is going up. And the picture on the right there is a gene expert machine. Here I wanted to tell the audience that we have this opportunity to use gene expert as a point of care machine, but those who are close to HIV viral load monitoring would agree with me. This innovative approach is underutilized, because some of us may say because they were deported, they were placed for TB services. Now the HIV guys can't use them. They are all over the country. We can supply the right cartridges for people to do the viral load, but things are not happening the way we wanted to. So this is an opportunity, but it's not tapped. Another method of treatment monitoring is HIV drug resistance. We are doing everything to prevent our drugs from being not effective by preventing the virus becoming resistant to treatment. So one of the methods we are using is enhanced adherence and counseling for those who have indication, those who are found to have a viremia, more than 1,000 copies. They undergo enhanced adherence and counseling, and then repeat the viral load, and they are managed according to the second reading. The other measure is early warning indicators. These are a set of indicators in our routine services which may give a signal to us regarding the potential of increasing drug resistance. So we have a number of them, including missed appointments, lost to follow up, if people are not coming to clinics, and there are several indicators which are showing, but if you can't do surveys on drug resistance, it helps countries to give them alarm that we are not doing well. But also we switch or substitute ARVs, and the standard would be for any person who is found to have high viremia to do genotype, to do molecular tests to see if the virus is resistant to a mutation. But because we are limited in terms of resources, as of now, only those who fail for the second line ART treatment are undergoing genotyping. For those who are failing the first line We only do enhanced adherence and counseling, do a second HBL, and still if the test shows high viremia, the patient is shifted into second line. So once you fail the second line, then only can we do genotype to see if there is a resistance. So, but the ideal would be any viremia is followed by genotype, but we are limited. The other thing I wanted to share with you as a progress is availability of INSTI primers for carrying out resistance. INSTI drugs, a class of drugs in which DTG is belonging. So we didn't have these primers for doing drug resistance. We now have it, and we will monitor our DTG, because DTG is also used for second line. So once we have mutation for drugs, we depend on disasters be with us. So the other insight I wanted to share here is we have a third line cohort. We have established a cohort of those who have been shifted into third line to follow up over time to see what is happening. So with those few highlights, I think I've come into the end of my presentation, and thank you very much for your attention, and I welcome for sharing your experiences on how we can further improve on this. Asanteni sana.
Thank you very much. We are ready to